What's up, Ninja Nerds? In this video today, we're going to be talking about antiplatelets, anticoagulants, and thrombolytics. Again, this is a part of our clinical medicine section. If you guys like this video, makes sense, helps you, please support us. You can do that by hitting the like button, commenting on the comment section, or subscribing. Also, do yourself a favor, go down in the description box below, click on the link. Do it now. Did you do it? All right, good. Now, go to our website. On our website, if you become a member, you'll have access to notes, illustrations, quiz questions, and even some exam prep courses that we're making. So go check it out. All right, let's get into it. All right, so let's start this off talking about antiplatelet medications. Big thing to remember, antiplatelets are really good at inhibiting platelet aggregation. That's their primary goal, which basically prevents the clot from getting bigger. They don't break down a clot. They just help to prevent clots as well as prevent the clots from getting bigger. Now, let's think about this. When you talk about antiplatelet medications, there's a couple different groups. The big one, the heavy hitter, is aspirin. Aspirin is super common. The reason why when we think about aspirin, platelets, whenever they're either activated because of damage to the endothelium, or they just stick to the platelet, the platelets stick to the endothelium for undesirable reasons. When they do, they have to tell other platelets to become activated and stick to it, which makes this platelet plug get bigger. So what they do is they release things like thromboxane A2, ADP, and another one called serotonin, 5-hydroxytryptamine. Now, once these platelets are activated, they'll release these cytokines, and these cytokines will come here and act on these platelets, stimulate them, and then make this platelet plug get bigger. We don't want that, right? And we would also like to keep the platelets inactivated in general. So what I'm going to do is, I'm going to give aspirin, and it's going to inhibit thromboxane A2. And what that's going to do is that's going to inhibit platelet activation and therefore platelet aggregation. So it's going to inhibit platelet aggregation. That's my whole goal. And also, I would like to inhibit the platelets from becoming active and sticking to the endothelial lining in general. Right? So that's my goal. So when I think about this, how does it actually do this, inhibit thromboxane A2? Well, inside of the platelet here, we have a molecule. It is called arachidonic acid. Arachidonic acid is eventually metabolized into a bunch of different prostaglandins, which we oftentimes abbreviate PG. Right? There's PG, I2, E2, H2, G2, all these different things. Really good for inflammation, good for fevers, right? The other one is thromboxane A2, which we're going to represent as TXA2. When we go through this pathway, right, and there's other ones, leukotrienes. When we go through this pathway, arachidonic acid is metabolized via an enzyme called cyclooxygenase. And the cyclooxygenase enzyme will help to catalyze this step. So we're going to put COX. Keep your minds clear, right? So there's COX-1 and there's COX-2. What happens is COX will help to stimulate this process to convert arachidonic acid into prostaglandins and thromboxane A2. When you give aspirin, that inhibits this enzyme, which prevents this process, right? And so what happens is you get less prostaglandin production and less thromboxane A2 production. The benefit here is thromboxane A2 is for platelet aggregation. Prostaglandins, we'll talk about this later, but these are supposed to promote inflammation and fever. So guess what you'll get from this? Just as a side note, and that's why we use aspirin for this as well, you'll get a decrease in fever and a decrease in pain. So decrease in fever, and really what we say is inflammation, which may cause pain. So it can act as an anti-inflammatory and can also act as an antipyretic, as well as inhibiting platelet aggregation, so an antiplatelet. So think about this. Thromboxane A2, it's supposed to be released from these platelets, right? To go and signal to other platelets. So now we're making less of it. If I make less of it, what's going to happen? Well, here's another platelet. Thromboxane A2 is supposed to come over here and act on these receptors. And when they act on these receptors, it triggers an intracellular mechanism which is supposed to help with the expression. Where's my pink marker here? Here we go. This pink marker is going to represent what's called GP IIb 3A. You're like, what the heck? That's a heck of a name. And then normally what should happen is you have platelets. They want to stick to one another, right? In order for them to stick to one another, they need that GP IIb 3A protein there. Thromboxane A2 goes on, acts on this receptor, triggers an intracellular mechanism which is supposed to help to phosphorylate these. Generally will help there's what's called a intracellular pathway where will lead to cyclic AMP and protein kinases. Normally you phosphorylate them. What happens is you actually want these to be in the active state, so you don't want them to be phosphorylated. And so that will make them active. So what you're trying to do is is get these GP2B3A to be active. You want to activate it, right? Once they're active, what happens is there's a protein in our circulation called fibrinogen, which is supposed to stick between this GP2B3A from platelet 1 and this GP2B3A from platelet number 2. And when they stick, that's how you get this big platelet plug. If I give thromboxane A2, what it's going to do is, if I give aspirin, it inhibits thromboxane A2. Now I have less signaling to activate the GP2B3A. This signaling will be shut down. The GP2B3A will remain inactive. Will I be able to allow these platelets to stick to one another now and form a platelet plug? No. And this will no longer stick. And that's how we inhibit this. Tell me that's not cool, right? All right, that's aspirin. Let's go to the next step here. Next one is a P2Y12 blocker. There's actually a bunch of these little sons of guns. There's most common one is going to be clopidogrel. I say we use this one a lot. Plavix. Another one I actually prefer is ticagrelor, also known as Brilinta. And then you have another one called prasugrel. I'd say out of all of these, the prasugrel is the one that, so generally all of these are kind of like what we'd say blood thinners. This one probably has the highest bleeding risk out of the P2Y12 blockers. When we give these medications, again, what you're thinking about is how do they work? Well, when platelets stick to the endothelial lining, they release, again, what are the chemicals? Thromboxane A2, ADP, serotonin, right? So we'll go back, serotonin. We'll go back, thromboxane A2. And then we have ADP. Guess which ones these block? They don't necessarily block the synthesis of ADP. What they do is they inhibit the action of ADP. So let's actually only focus on that one. They inhibit the action of ADP on these platelets. So ADPs are supposed to come over here and act on these platelets. Guess what? We're going to inhibit that. We're going to inhibit the interaction of ADP on the platelets. If you do that, you inhibit platelet aggregation. You inhibit these platelets from becoming activated and sticking to the other platelets. You're going to prevent the platelet plug from getting bigger. So you're going to inhibit platelet aggregation. That's pretty cool, right? Now, how exactly? All right. Here's your ADP, released from a platelet. It'll go over here, act on this platelet, right? And there's a receptor here. And this receptor is called the P2Y12 receptor. That's what these little puppies are right here. Pop and pop. When you give ADP, ADP is supposed to act on the P2Y12 receptor. It's going to activate it. When you activate it, it should intracellularly work to do what? What it's going to try and do is it's going to increase, it wants to activate the GP2B3A. So it'll send signals that'll hopefully do what? Increase the expression or activation of GP2B3A. That's its goal. So it would increase the expression of this. So let's say here's that platelet that got activated, right? ADP, hit it. It would express GP2B3A. Let's say this one was also ADP hit it. It would work intracellularly, increase the expression of GP2B3A. Now, if I naturally, here's my GP2B3A, my GP2B3A, same thing over here, GP2B3A. These are all those proteins. This naturally, when ADP hits it, it stimulates this pathway, right? So naturally wants to stimulate this and turn this into the active form, right? When you give a P2Y12 blocker, guess what they do? A P2Y12 blocker blocks at the P2Y12 receptor. When they block this receptor, they're no longer going to stimulate this intracellular pathway. They're going to inhibit this intracellular pathway. They're no longer going to keep the GP2B3A in an active state. It'll now be inactive. If this is inactive, is it going to be able to allow for a connection between fibrinogen, between this platelet and this platelet? No. And so this interaction will be inhibited. So these platelets won't stick to one another. You won't be able to make a platelet plug. Do you see why that's cool? Because you're inhibiting platelet plugs and you're also inhibiting them from getting bigger. That is the cool concept about these. Now, it's also important to know, clopidogrel is one of those drugs where it is metabolized via the liver. So let's say here, I have the liver, and clopidogrel is metabolized by that, right? There's an enzyme. Let's represent this enzyme here in like blue. So here's my enzyme, and here's going to be my clopidogrel. So clopidogrel is metabolized via this CYP2C19 from a inactive, so we'll put this as inactive, or into like an active form, right? And so it has to get metabolized via this enzyme. Some people have polymorphisms in this enzyme. And so some people, you may have a hyperactivity of this enzyme, and they'll metabolize, and they'll be really good responders to the drug. And you have other people who have decreased activity of this enzyme, right? And they'll be under responders. And that's why it's really important. So in patients who have what's called CYP2C19, so if a patient has a CYP2C19 polymorphism, meaning that they have different activities of this enzyme, what you have to do is you have to check a P2Y12 level. So you always should check a P2Y12 level. If that P2Y12 level is high, it tells me the patient is a under responder. They're not inhibiting that P2Y12. You shouldn't keep giving them that drug. They're at high risk of forming a thrombus. And if their P2Y12 level is low, that means they're a hyper responder. And that means that they're responding very well to the drug, but they do potentially carry a slight higher risk of bleeding. And so that's an important concept to understand, is that some people have this polymorphism. You check the P2Y12 level to see where do they fall in that. Is it a normal range, good responder, hyper responder, or under responder? That's the importance of knowing that. And ticagrelor doesn't have to go through this process, and that's what makes him a little bit more attractive, is that if a patient has a hyper or under response, you can give ticagrelor because it's not dependent upon that process. The next one is your GP IIb/IIIa inhibitors. There's a couple of these. So there's going to be what's called apixaban. There is another one called tirofiban. And I'd say this one I see commonly is aPTT. This is really testing my spelling ability today. So these drugs are cool, man. I really like these because what they do is, remember the platelets, right? They're secreting all those things like the ADP, the serotonin, the thromboxane A2. All of those things are getting released from the platelets to go and like tell other platelets to come by, right? These are all intact. These are fine. You're not inhibiting these. What you're actually going to be inhibiting is, remember this thing here, the GP IIb/IIIa? That's what you're inhibiting. You're inhibiting the connection. So if you think about it, it kind of goes back here. When you look at the platelet, it has a bunch of different receptors, right? If you really wanted to think about it, it has what's called a GP IB. These are important for connecting with, this is your GP IB. This is important for connecting between platelets and von Willebrand factor. You can just annotate that. But the other one that's important between connecting from platelet to platelet is the GP IIb/IIIa. So here's your GP IIb/IIIa protein. And what's supposed to connect between those is the fibrinogen. So here's your fibrinogen, which is a coagulation protein. That's normally going to allow the platelets to stick to one another and form a platelet plug. If I give a GP IIb/IIIa inhibitor, guess what they're doing? They're blocking this. They're going to directly inhibit this completely. There's no interaction intracellularly. There's anything at all to do with the cyclooxygenase pathway, nothing to do with the P2Y12 receptor. It just literally goes right to the source. All of these inhibit the active state of GP IIb/IIIa. This one just goes straight and blocks GP IIb/IIIa at its source. Now, if that happens, you can't have these platelets aggregate. If they can't aggregate, you're not going to be able to make that platelet plug. So that's the concept. Now, these are really, really strong medications. I'd say they carry out of all of these the highest bleeding risk. So when you think about this, it's really important to know that high bleeding risk with these. When you take all of these and you compare, like, which one of these would potentially give me the highest bleeding risk, this would be the one. Now, with that being said, it also makes it one of the most potent antiplatelet medications. We don't always give this, and we'll talk about when, but there is patients who are high risk, and that's when we would consider this medication. We'll talk about that a little more in the algorithm, as well as when we get to the indications. All right, so your PDE3 inhibitors are going to be including silostazol and dipyridamole. Now, I would say for these, they're not commonly utilized. I'd say if anything, silostazol, we'll talk about where it's actually kind of utilized. I'll give you a little sneak peek. We kind of use it in people who have PAD with like claudication, so like pain in their calf muscles, usually when they like walk up hills or they get some exertional activity. Dipyridamole, we use it maybe in stress testing. And so that's something that we'll talk about how it actually does that. But in general, it's kind of unfortunate we have to do just a quick dive, I promise, just a quick little dive into the intracellular pathway. So there's an enzyme in this pathway that's actually kind of critical, and it's called phosphodiesterase 3. And it kind of keeps some checks and balances, if you will, on this pathway. So what is this pathway? There's an enzyme inside of all these cells, and it's called adenylate cyclase. You're like, oh my gosh, we're doing this crap, huh? This guy converts adenylate cyclase into cyclic AMP. Cyclic AMP activates what's called protein kinases, especially like protein kinase A, and that turns a molecule which we call VASP into the phosphorylated form, right? Which is that's what a protein kinase does. They phosphorylate things. And so this is kind of the steps that we get here. And then this phosphorylated VASP protein, what it does is naturally, it goes and acts on another protein, which is called GP IIb3A. Here's the thing. When this VASP is in this state, it's kind of like inactive, if you will. And so it's not able to kind of keep these GP2B3As in their active state. And so what I want you to remember is that these naturally help to do what to the GP2B3A. We'll use like a negative sign here that it keeps it kind of slightly inhibited, all right? PDE3 actually works here, and what it does is it degrades cyclic AMP. So now think about this. This pathway normally is trying to inhibit GP2B3A. This enzyme keeps your checks and balances, so it inhibits cyclic AMP. If I inhibit cyclic AMP, I end up with lower levels. I end up with less protein kinase A, and I end up with less of the phosphorylated form, which keeps this now in what? In a stimulated state. So that's how you get your checks and balances. If I give an inhibitor of this enzyme is going to be inhibited. I give silostazol, I give dipyridamole. If that's the case, this is no longer breaking down cyclic AMP. So what's going to happen? Well, I can kind of say in a way I'm stimulating this pathway instead. And so instead, I'm not going to break down cyclic AMP, I'm going to cause him to build up. That means that my kinases build up. That means this pathway is catalyzed. And that means that this VASP is really allowing the GP2B3A to be in a hyper-inhibited state. And now, this puppy is inhibited like a son of a gun. If I can't activate him, he's in his inactive form. This is a problematic scenario, as we've seen, because now this platelet here is under the effect of a phosphodiesterase inhibitor, and this one here is under the effect of a phosphodiesterase inhibitor. These aren't even working. So you throw fibrinogen in here, it don't matter, bruh. What's going to happen? These things aren't going to allow for the activity and the clicking of platelets and the aggregation to occur. That's where we get this inhibition of platelet aggregation. But there's something else. So here, you're going to get the antiplatelet effect. All right, that's kind of cool, right? You get that antiplatelet effect. But you probably are thinking, like, dude, I don't really see when I use these. There's an important thing to remember. PDE3 inhibitors, they not only represent like this, right? So PDE3, I'll just do it like this. I'll at least start with a little abbreviation. These also work on smooth muscle. When they work on smooth muscle, they do the same kind of process. And so in smooth muscle, especially in our blood vessels, it causes them to relax, right? If these muscles relax, what will that do to the diameter of the vessel? Make it big, baby. That puppy gonna dilate. You can get some vasodilation. Now, if that vasodilates, what would that be beneficial in? If I got an antiplatelet effect and a vasodilation effect, you know what this could be really good in? It could be good in a disease where there's plaques in the vessel and they're also little flow. This would really be a good scenario where we could consider this in PAD. So we'll give it in patients who have PAD, but particularly they have claudication. What the heck is claudication again? They got pain whenever they exert themselves. Because what happens is the muscles need more oxygen. They're not getting it because they have a plaque, and you're going to prevent that plaque from actually causing a thrombus, but also you're going to vasodilate those vessels to increase the flow. So it helps to get more oxygen to the muscles. That's the time where we'll use cilostazol, dipyridamole. We primarily give this drug because of the vasodilation effect that you get in the coronary vessels. So it's good in stress testing. All right. Nonetheless, we've talked about that one briefly. I want to focus on these. So in patients who we actually give this medication to, it's really good in patients who have atherosclerotic cardiovascular disease. So let's say a patient has a past history. They've had a stroke, right? So it's really what I would like to say is we utilize it in secondary prevention primarily. And what that means is they have, let's say in the past, they had a plaque. That plaque fissured. When it fissured, guess what decided to happen? Platelets were hanging around and they started sticking. And when they stuck, they ended up causing a clot. When they clotted off that vessel, now what do? You reduce blood supply. And as you reduce blood supply, you reduce oxygen supply to particular tissues. And what are those most common tissues? The heart, the brain, and the lower extremities. As a result, a patient could get maybe coronary artery disease. They could develop a stroke, or they could develop peripheral artery disease in their leg. When this happens, they develop these complications, right? So in other words, they have a history. So what I mean is they had a prior CAD, CVA, or PAD. You want to prevent the next event. You don't want them to get another MI. You don't want them to get another stroke. You don't want them to get limb ischemia. And so that's when you'll give aspirin. And so generally we like to do aspirin, 81 milligrams, and I'm going to abbreviate that ASA. We like to do 81 milligrams. And what that's going to do is prevent future thrombotic events. Because what are you going to do? You're going to keep aspirin in there, and guess what that's going to do? That's going to inhibit platelet aggregation. The platelets won't stick, and if they do stick, they won't continue to stick with other platelets. So that's the cool concept here. So it's really important to use this as a preventative. There is scenarios in high-risk patients where we'll do it as a primary prevention. So the only time that we actually do like primary prevention, is in a patient who has a high risk. So they have super high risk of these events happening, but they didn't develop clinical events. What the heck does that mean? You do a calculation on MD Calc. The atherosclerotic cardiovascular disease risk, if that over a 10-year period is greater than or equal to 7.5%, then you can do aspirin or ASA at 81 milligrams daily to prevent them from developing events like CAD, strokes, and limb ischemia. Okay, so aspirin is really the big one here for atherosclerotic cardiovascular disease prevention. I don't use any of the other ones? No. Now, if a patient has a intolerance to aspirin, they develop like weird allergic reactions or something else, you could use a P2Y12 blocker, but that's not often too common. All right, acute coronary syndrome, really important. Here we have a coronary plaque ruptured, you develop a thrombus. That thrombus does what? Reduces O2 supply, baby. You reduce that O2 supply to the myocardium, what's going to happen? Well, it's going to be pissed, I can tell you that much. And it can start to develop ischemia. Worst case scenario, you infarct, right? Now you don't fart, you infarct. So this is important to remember. Depending upon the degree of ischemia or the severity of thrombosis can determine if you have something like unstable angina, NSTEMI, or STEMI, right? So that unstable angina is ischemia to the myocardium, usually the bottom layer, with no troponin elevation. NSTEMI is infarct of the bottom layer in a troponin elevation. And then STEMI is going to be infarct of the entire layer of the myocardium, transmural, and a troponin spike, right? ST elevation, ST depressions. When this happens, and you see these patients, and they come in with ripping, tearing chest, not tearing chest pain, the chest pain that's heavy, right? Then what do? First thing we do is we give aspirin, 325 milligrams. Then we add on a P2Y12 blocker. And usually this is a load. Clopidogrel, maybe 300, 600 milligrams. Or you can give ticagrelor. The next one is you add on IV heparin. And usually this is unfractionated heparin. These will be given to the patient as an initial therapy. What you're doing is you're giving these medications to try to inhibit that clot from getting any bigger. That is your goal. You want to give these to inhibit the clot from getting any bigger. You want to inhibit platelet aggregation, inhibit secondary hemostasis. Give yourself time, because guess what you're going to do with these patients eventually? You're going to take them to the cath lab and you're going to do a PCI, percutaneous coronary intervention, and the hopeful goal is that this patient will likely end up with a vascular stent. Oh, that's kind of cool how we like to do that. I got you, bro. So we load them up with this triple therapy, get them to the cath lab, clean out the clot, and then put in a stent. So now we've cleaned out the clot. Look, the clot's gone. You see that? We got rid of it. Now, one other thing. Zach, you talked about GP IIb/IIIa inhibitors. Do I ever do that here? Do I ever give it? Not too often. Now, what we may do is you may consider adding on, like if they're going to the cath lab, you could do a plus or minus GP IIb/IIIa inhibitor. And I'm just going to add in an inhibitor. This is the one time where you could do it. Let's say that a patient comes in, they get, oh my gosh, chest pain, bro, chest pain. They go to the cath lab, they get loaded up with these medications. They're in the cath lab, they're trying to get rid of this clot. They got a big stinking clot. You may give that one. Another one is they get rid of the clot, but the flow afterwards, it's not good. Or they put the stent in and you clot off the stent. So bailout therapy may be a good one. But it's not too often that we give this one, but in certain scenarios it may be given. To go along with that for that vascular stent, so once we've cleaned out the clot, we're gonna balloon open the vessel and we're gonna put the stent in, and it's gonna help to establish good flow. Your goal is you don't want to get stent thrombosis. So my goal here is to prevent stent thrombosis. That's the primary goal. I want to keep this thing patent, baby. So how do I do such a thing? Well, again, if you're in the actual interventional suite, what you may have to do, this may be when you add on that GP IIb/IIIa. And I just want to write it here. It's primarily as a bailout therapy. And again, just so that you know what this means when you go back and refer to it, what I'm telling you is you're in the vascular suite, you've already given these medications, you open up the vessel and it reclots, or you get poor flow. Give this drug, it may help out. All right, that's really the only time. But after the stent's been placed, we don't give that drug. What do we do then? Get rid of the heparin. Now, what you're gonna do is you're gonna put them on aspirin, 81 milligrams, plus what else? A P2Y12 blocker. And you're gonna do this for about 12 months. The whole goal is you're doing it to give time for the endothelium to kind of line that stent. Because you don't want them to not have that. Once they endothelialize that stent, you're good. But you got to give them time to do that. So this helps to prevent thrombosis in that time frame. Then, after 12 months, so post 12 months, guess what you go on to prevent the stent from thrombosing in the future? But that doesn't usually happen. It's more preventing atherosclerotic cardiovascular events. Aspirin. Then it's just aspirin, 81 milligrams until they are 6 feet under, right? And not in a bad way, I don't mean that, but like hopefully they live a long and fruitful life where they don't have any of these events. But that's the concept. So you see here how we can utilize these medications. They come in, hey man, I got a history, aspirin, if they have these history. My risk is high, aspirin, I don't want you to develop these events. You develop an event, especially acute coronary, triple therapy as we talked about here, but you're gonna see this one and this one. Heparin. Add on here sometimes. Really the only time we add it on for the acute coronary is if they didn't get this or it's not working fast enough. Then they get to the vascular suite. They go clear out the clot. After they clear out the clot, if it re-stenosis or you get poor flow, give this one. If it's good, give them something to prevent that stent from thrombosing in the future. These two. After the 12 months, then continue aspirin. All right, my friends, we covered that. Now let's move on to anticoagulants. All right, so now we're gonna move into the anticoagulant medications. So these are really helpful at, again, preventing the clots from getting bigger. They don't necessarily inhibit platelets. So they're not designed to inhibit platelet aggregation and the primary hemostatic kind of plug. They inhibit the secondary hemostatic plug. Right, so that formation of the fibrin mesh. But they still help to prevent the clot from getting bigger or propagating, as we would say. So we have to talk about these, particularly discussing the coagulation cascade first. So if you guys remember, we have an intrinsic pathway and an extrinsic pathway. So when we talk about these, I want you guys to not go too crazy because we talk about this in the coagulation cascade and hemostasis, but intrinsic pathway, do you guys remember in order which ones we're talking about here? It always starts with factor 12, right? And then factor 12 will become activated when it gets in contact with a negatively charged platelet surface. That then will go and activate what? Factor 11. And then factor 11, when it becomes activated, it goes and activates what? Factor 9. And then factor 9, when it's activated, will combine with factor 8. And that combination will lead to what? Hopefully converting factor 10 from an inactive form into an active form. That's the whole goal, is so that this intrinsic pathway will lead to what? The conversion of factor 10 into the active form. All right, that's the common pathway. Now, the extrinsic pathway is really looking specifically at what? At tissue factor. Now, tissue factor is released by injured endothelium. And whenever you have an injured endothelium, it helps to really help the activation of tissue factor, which is really factor 3. And then factor 3 combines with the activated factor 7, right? And factor 7 and 3, what do? They help as well. They converge onto a common pathway to convert factor 10 into the activated form, right? So I always like to remember intrinsic is 12, 11, 9, 8. And I like to remember extrinsic pathway is 3 and 7. Now, 3 and 7 give you 10. And then for 12, 11, 9, 8, you're skipping 10. The next part here is, in order for the activated factor 10 to lead to the formation of thrombin, because you know thrombin is in the prothrombin state, and then it has to go into the active state. So this is my thrombin. I need the presence of factor 10. But I also need the presence of another factor here, which is factor 5A. And factor 5A is formed by the presence of thrombin. Now, when these two form, they lead to that process. And then thrombin is essential for what? Converting fibrinogen, which is this factor 1 here, into 1A, which is fibrin. You have to remember that fibrinogen is kind of just like monomers, and then fibrin is a bunch of those fibrinogen monomers polymerized together to make one big fibrin strand. But this process is heavily dependent upon thrombin. And then what happens is thrombin helps to catalyze the cross-linking. And so eventually there'll be another process here where we'll need another factor. I'm just going to mention him briefly. It's dependent upon factor 13. And that's really where thrombin helps to activate this one. So then we get this like cross-linked fibrin. The whole concept here is that cross-linked fibrin, you already had the platelet plug. So the platelets will start sticking, release ADP, thromboxane A2, serotonin, cause more platelets to come over, and they stick to the other platelets. How? GP IIb3A. That's formed. Primary hemostatic plug is formed. you led to this pathway leading to fibrin mesh. That fibrin mesh will then anchor that down. And that's how you get the secondary hemostasis, right? And so that's where you'll get a secondary hemostasis. What we did before with all the antiplatelets is we were inhibiting primary hemostasis. Here, you're inhibiting secondary hemostasis by giving anticoagulants. And that's how you're going to get thrombosis, right? We want to prevent that plug, that thrombus from getting bigger. So how do we do that? All right, watch this. Heparin is a very commonly utilized drug. We use it a lot. Okay? One of them is unfractionated heparin. Unfractionated heparin is really good. It's got a short half-life, one of those medications that is good to allow for ease of titration. So one of the benefits of unfractionated heparin is that it can be used in a titration. All right, so we can use it as an infusion because it has such a short half-life. So it's great as a titrating medication. Because you're titrating it though, you need close monitoring. And oftentimes the way that we will monitor the unfractionated heparin is we will check their PTT. A lot of newer protocols though are going on to anti-10A levels, and you'll see why in a little bit. But remember what PTT is a harbinger of, or at least it's a monitor or parameter of? It tells me about the intrinsic pathway. Because heparin, you'll see here in a little bit, inhibits factors 10, which is a part of the common pathway, and thrombin, which are a part of the common pathway. You're like, okay, that's not for the intrinsic, but it also inhibits these factors. All right, the most of them is 9, that's the biggest one, but it can inhibit all of these as well, to less of an effect. The other one that we can give is going to be low molecular weight heparin. Low molecular weight heparin. This one isn't a titration. So this one's IV. It's an IV form, and so it's really good for like a titrating one, right? Because of a short half-life. This one we give as an injection. This one is usually a sub-Q, and it's usually a twice daily sub-Q injection. This is usually by weight, right? We don't ever really have to monitor anything for this one. That's the benefit of it. But the thing to remember with low molecular weight heparin is it has a long half-life. So that's why we use it not as a titration, but as a twice daily injection. The thing with this one is, only time we would really monitor this one, the anti-10A level, we would do this in patients who are very obese, but more specifically, severe renal failure. And the reason why is heparin is renally cleared. And so if a patient has severe renal failure and they can't clear the heparin as well, you should definitely be keeping a closer eye on their actual 10A levels. So I'll only really check this level if they're bleeding or if they have obesity or renal failure. All right, those are the scenarios where I would have to be a little bit more cautious. There is another one that we give, and this one is going to be a synthetic one. And this one is called fondaparinux. So this is called fondaparinux. This one's great. It's a synthetic heparin. I'd say this one's great. We're finding a lot more utilization of this one. This can be for use a lot of prophylactic scenarios, but this one's also an injection. So this one, I really like this one, but it's basically a synthetic heparin. The concept behind these is that unfractionated heparin, it just means that you have the heparin molecule. When you look at its structure, it has the heparin and then it has this like glycosaminoglycan that makes it really long. Low molecular weight heparin is it has the heparin structure with a very short glycosaminoglycan. Fondaparinux is just that heparin structure, no glycosaminoglycans. That's kind of how you get a little bit of the name. Now, heparin in general, what it does is it acts on a protein called antithrombin 3. And all it helps to do is just increase the active state of antithrombin 3. So basically kind of puts it into a hyperactive state. Antithrombin 3 is designed to inhibit a couple different factors. One is it will inhibit factors 10, right? So it's going to inhibit factor 10. The other thing it's going to do is it's going to inhibit thrombin. But the only one that truly, out of all of these, that inhibits thrombin is unfractionated heparin. So let's put that down. Only unfractionated heparin inhibits both thrombin and 10. So when you think about these are 10A inhibitors primarily, with unfractionated heparin having a little bit of thrombin inhibition. Now, heparin is a great drug. It's just important to remember, the big things to take away from this one is it's more honestly utilized in a acute scenario. It's the best way I want you to think about it. And when you give one unfractionated, usually for titrating it, very close knit control, monitor PTT. Low molecular weight, you get more liberal. You can give it twice daily. You can give it for a lot of different scenarios. You don't have to monitor things as well unless they have certain comorbidities. And then synthetic fondaparinux is really great, especially if a patient has a true allergy or a heparin-induced thrombocytopenic reaction to these two. I had to move this guy out of the way. I'm sorry. So direct 10A inhibitors were over here, but I got to bring it over here because, again, what do I want it to do? I wanted to actually inhibit this, and so I didn't want to have some wonky arrow here. So the big thing to remember is for direct 10A inhibitors, they're unlike heparin. This one works indirectly. These ones, they go straight to the source, baby. They act right here. And they shabloink, inhibit this puppy. So now this enzyme is straight up inhibited. So we got to think about the drugs that we would utilize in this scenario. All right, so there's a couple. I think the two biggest ones that are most often used is going to be apixaban. So that's apixaban. And then the other one is often referred to as Eliquis. And then the other one is rivaroxaban. And this one is often referred to as Xarelto. So these are great drugs. The benefit of these drugs is that they don't require any monitoring. You don't need to monitor a PTT, a 10A level. You could do a 10A level, but it's not often necessary. And so that's one of the benefits and the attractiveness of these drugs. So again, direct 10A inhibitors are going to inhibit 10A. Now, direct thrombin inhibitors, all right. So look, heparin's he's a heavy duty hitter because the unfractionated version can do both of these. Direct thrombin inhibitors, they go straight here. Look at that. So if you inhibit this one, what would these heavy hitters be? All right. So direct thrombin inhibitors, it actually comes down to two groups. So let's actually group this off into two different areas. So you have two types. One is going to be the oral thrombin inhibitors. What would this one be? This is going to be dabigatran. Dabigatran, baby. The other one is going to be your IV, or your parenteral thrombin inhibitors. What are these? These are going to be argatroban and bivalirudin. When we talk about these, here's the thing. You're probably like, okay, you got IV version here. Well, I know you said that this one was IV, and so it's really good for a kind of a titrating it, and really you got a short half-life, so it's really good for people who are in the hospital. This one, you could be in the hospital, you could go home with an injection. This one's also an injectable as well. All right, cool. So what's really the scenario where this would be more beneficial or attractive than these? Well, obviously oral, I could take this home, but IV, really the only time where this is truly utilized, and I'll hit you with it now, we actually utilize this as an alternative. This is really the only true indication for these in clinical reality, but it's an alternative to heparin in a patient with what's called HIT, heparin-induced thrombocytopenia. That's really the only time we're going to use these drugs. We can use all these other ones in various different types of scenarios. But again, these we only use in HIT. That's the real big kind of takeaway. So again, what I want you to remember is the IV thrombin inhibitors really only use it in HIT. We see here that these act indirectly to inhibit 10 in a certain scenarios thrombin. These act directly to inhibit 10A. This one acts directly to inhibit thrombin. What about this guy? This head honcho is insane. I like this guy. I like the mechanism. I don't like the drug itself, unfortunately, but you'll see why. So warfarin, what it does is, and it actually gets metabolized first by the liver, and then it actually can act on the liver. So when warfarin is taken up, it's important to remember that it's metabolized by something called the cytochrome P450 system. So I really need to tell you this. So it's metabolized by the cytochrome P450 system. So we call CYP 450. Now, the reason why this is important is because other medications or drugs per se could interact with the CYP450. And so it's important to remember this. So, because everything that we're going to talk about here, the mechanism of warfarin, it could either be downplayed or overplayed, and you can end up with super therapeutic levels of warfarin or subtherapeutic levels of warfarin. And so it's really important to get an understanding of this. And so because of that, there is two different things that we need to talk about. One is there's drugs that can act as inducers. And inducers, essentially what they do is they act on the CYP450 system and they metabolize warfarin easily into what? Into the inactive state. And if warfarin is inactive, it's going to decrease the activity of warfarin. One of the ways that we monitor warfarin is the INR. It kind of gives us a level. So just like heparin, we monitor the PTT, warfarin, we monitor the INR. If a patient is on warfarin and they're taking another drug that acts as an inducer and it lowers the effectiveness, what would you expect to happen to the INR? If INR is high, it means warfarin is working real well, too well. And if INR is low, it means warfarin's not working too good. So what do you think would happen? The INR will go down. Yeah. So inducers decrease the INR, increase the risk of thrombosis. But if you take a drug with warfarin and that drug acts as an inhibitor of the CYP450 system, then warfarin will not get metabolized into the inactive state. It'll remain active. If it remains active, then it can become super therapeutic. What can happen to the INR if warfarin's working way too well? It will go up. What's the risk that you run if INR is super therapeutic? Bleeding. That's why it's really important to remember. So now, let's talk very briefly here. Warfarin, it acts on a really interesting enzyme. Vitamin K, usually, it's in two different forms. We're going to say here, we're going to go from the oxidized form into the reduced form. And in order for me to go from the oxidized to the reduced form, or from the reduced form to the oxidized form, I need enzymes. The enzyme catalyzing this step, I'll make it a cute little blue one. This is called vitamin K epoxide reductase, because it wants to reduce the vitamin K. So we're going to call this one vitamin K epoxide reductase. So when warfarin goes to the liver, it'll actually get taken up by the liver, get metabolized, get spit out, and then guess what? It then goes and does its job back on the liver. So here's going to be our drug. Here's our warfarin. Gets taken up by the liver, so first pass metabolism. Then it gets metabolized, and then it goes back and acts on the liver. And what it's going to do is, it's going to inhibit this enzyme. It wants to inhibit the vitamin K epoxide reductase. Will this process occur? No. If this doesn't occur, then I don't have the reduced form of vitamin K. The reduced form of vitamin K is important because there's another enzyme, and that enzyme is a gamma glutamyl transferase. So it's a GGT enzyme. What color should we use for that one? Let's use this maroon color. Here's this enzyme. This enzyme is crucial because it uses the reduced form of the vitamin K, and what it does, the liver makes proteins. And these are going to be factors 2, 7, 9, 10. You're like, oh my gosh, wow, that's a lot of different factors. They're in the inactive kind of like, they're not the truly functional state. But if vitamin K is present, this enzyme will then utilize this process to make them functional. So now you're going to have functional 2, 7, 9, and 10. Oh, wow. So now watch this. If I inhibit this enzyme by giving warfarin, this enzyme is inhibited. I'll have less of this reduced vitamin K. If I have less of this reduced vitamin K, is this pathway going to occur effectively where this GGT enzyme will use the reduced vitamin K and convert these inactive factors into the true functional factors? No. This process will be inhibited. And I'll end up with less of these factors. So now look, I got less factor 2. What's factor 2? Thrombin. This becomes affected. I got less factor 7. Where's factor 7? Right here. This becomes affected. I got less factor 9. Where's factor 9? This becomes affected. And 10. 10. Oh my gosh, this becomes affected. You see how heavy hitter of a warfarin is? This dude attacks multiple different pathways. Intrinsic, extrinsic, common. Now with that being said, warfarin is going to have the most profound effect on our extrinsic pathway. Let me explain why. Out of all of these factors, the first one to drop the level, the first one to drop, and with the shortest half-life, is factor 7. So factor 7 levels will drop because it has the shortest half-life. All right, so we're going to say here it has this level will drop. Why? Because it has the shortest half-life. And that's actually T1/2, sorry, T1/2. So because it has the shortest T1/2, its levels will drop quickly. All right? So if you have the shortest half-life, boy, that thing will drop. If it drops, what's going to happen? That means that the one pathway that becomes most affected is the extrinsic pathway, more so than the other common and intrinsic pathways. What is the parameter that we use to monitor the extrinsic pathway? PT-INR. PT-INR. So warfarin, you monitor the INR because why? Because it's going to drop the factor 7 level first. That will have a first effect on the extrinsic pathway more than it will the intrinsic and other pathways. So that's why it's really, really important to know that, okay? So I think we've done a pretty good job discussing these anticoagulants, their mechanism, some of the monitoring. So when I say heparin, PTT, when I say warfarin, INR. But remember, warfarin can also have an effect on PTT as well because it is inhibiting some of the parts of the intrinsic pathway, but more so extrinsic. So we see how all of these drugs are working in different types of ways, but I want you to look at the end point, that in some way, shape, or form, they're inhibiting the parts of the extrinsic, intrinsic, or common pathway. In some way, shape, or form, we're at least leading to downstream a decrease in thrombin, right? Why is that important? If you don't at least lead to good amounts of thrombin, that's supposed to convert this into this. So if I have less of this one, through all of these pathways, either they do it directly or indirectly, that's going to lead to less conversion here, less fibrin, less of the cross-linked fibrin. I don't make the fibrin mesh. And then what happens? I decrease the secondary hemostasis because I'm trying to prevent the clot from getting bigger. So it's really important to remember all these. Now, one last thing. The inducers and inhibitors, it's really important. Sometimes on the MCQs, you'll get a little bit of a question on these. So if you ever see a patient who comes in, they're on warfarin and they're on another medication, they mention this, and they have either a low INR and a high INR, remember these things. So inducers. We use a mnemonic, it's called CRAP GPS. So what does it stand for? It stands for C, carbamazepine, R, rifampin, A for alcohol use, but this is more of chronic use, P for phenytoin, and then GPS. G is griseofulvin, P is phenobarbital, and at S, St. John's wort, which we don't use too often. Now, the inhibitors, you got to be careful of these if a patient has a supertherapeutic INR. What would that be? Remember the mnemonic sickfaces.com. So sick for S, this is going to be sodium valproate, that's an antiepileptic. I is isoniazid, a tuberculosis medication. C, cimetidine, an antihistamine. K is going to be ketoconazole, an antifungal. F for the faces is going to be fluconazole, an antifungal. A is going to be alcohol use, but this time it's acute use, right? Acute alcohol intoxications. C could be another C, so let's say ciprofloxacin, which is an antibiotic. And then E is going to be erythromycin, and then S is sulfonamides. Think about Bactrim as an example here. The next part is .com, so we're going to skip the dot and we're going to go to the com. C, we'll use chloramphenicol. This is an antibiotic that can be used in tick-borne illnesses. O is omeprazole, which is a proton pump inhibitor, and M is metronidazole, which is an antibiotic. All right, so remember those as a little quick tip to understanding how they can act as inducers or inhibitors. Why do we give these drugs, right? They're good at preventing clot propagation. They don't want these things to get bigger. And so if a patient develops a DVT, so let's say here I have a vein in the leg, and they go get a Hock and Goober right in there, right? Hock 2. Right in there, right? If that happens, it's going to cause a lot of pain, leg swelling, right? Swelling. That's not a good thing. The reason why is if that thing pops off, it's going to pop off, what can happen? That clot could then break off from becoming a thrombus, go up the inferior vena cava, and then what can happen to that clot? Oh, the scary, scary thing. That thing can go and get stuck in the actual pulmonary circulation. You can get a PE, right? So we don't want these things to get bigger. I don't want the DVT to get bigger. I don't want the PE to get bigger. So what I will do is, in a patient who is a PE or a DVT that is not severe, extensive, we'll give these medications to prevent them from getting bigger. So oftentimes what happens is we'll start off with heparin, right? One of them. Oftentimes it could be low molecular weight heparin. And then what we'll do is we'll do that for a little bit while they're in the hospital or outpatient. And then what we'll do is for about 3 to 6 months, all right, we'll switch them over to some other kind of medication. Oftentimes that is usually either warfarin or a DOAC. And we'll do that for about 3 to 6 months. And then we'll do another ultrasound. So after the 3 to 6 month period, we'll come back and we may do another ultrasound to make sure that that's actually gone. All right? That's how we'll kind of treat these. Atrial fibrillation, it kind of depends. So when you have a patient with atrial fibrillation, your prevention, what you're trying to actually prevent is, remember, when a patient gets atrial fibrillation, they increase the risk of clots forming right there, right, in that left atrial appendage. If that puppy don't pop off, oh my gosh. If that thing breaks off, what's the most feared complication? There's a lot of different areas that this could embolize to, but the biggest one is a CVA, right? You don't want these patients to get strokes. That's the biggest concern. So my goal is to prevent these types of events from happening. So if a patient has valvular AFib, right? So you have to take the AFib. Let's say here's my atrial fibrillation, and I know, is it valvular or non-valvular? What does that mean? Do they have mitral stenosis or mechanical heart valve? If they do, it's warfarin. If they don't, it's a DOAC. So here, warfarin, because the evidence suggests this, and non-valvular is a DOAC. Let's be clear, I don't think I explained this enough. A DOAC is a direct oral anticoagulant. So when I say DOAC, I'm actually referring to a direct thrombin inhibitor that is oral, or a direct 10A inhibitor, which is oral, apixaban, rivaroxaban, or dabigatran. All right, please remember that. Because the only time we usually use this one is HIT. The next scenario where I would actually utilize these anticoagulants is if a patient has a mechanical heart valve. Mechanical heart valves are super thrombogenic, right? Highly thrombogenic. Not the prostatic ones, but these mechanical ones are super thrombogenic. And so because they're super highly thrombogenic, we want to prevent thrombi from forming on them. And so really the only one that we can truly give, the evidence-based one, is going to be warfarin. Now, it's important to remember, when a patient is on warfarin, you know that they can be on warfarin for a mechanical heart valve, they could be on warfarin for atrial fibrillation that is valvular, or they could be on it for long-term anticoagulation for DVT or PE. Heparin will monitor PTT, maybe anti-10A levels if they're on the low molecular weight. But warfarin, we monitor INR. For a DVT PE, you may aim for an INR of 2 to 3. For atrial fibrillation, the valvular form, you may aim for an INR of 2 to 3. But for this mechanical heart valve, you need a higher, because they're so thrombogenic, you need to have a little bit of a higher INR. And so we aim for an INR of 2.5 to 3.5. All right? So it's really important to remember these particular things. Now, one other thing that we did talk about here, and I want to mention it briefly, is remember, we talked about it over there. It's just an add-on, so acute coronary syndrome. I'll put in here, discussed in antiplatelets. But just remind yourself, what was the triple therapy? Do you guys remember? It was aspirin plus P2Y12 blocker plus IV heparin. So out of all of these heparins, which one do you think it would be? The unfractionated heparin. So I think that's deserving of a conversation. But again, I wanted you to remember that we utilize these medications as well, because we talked about it in the antiplatelet lecture, the antiplatelet portion, but it's also going to be an indication for giving anticoagulants. But the only one is really IV heparin. All right, we covered these. Oh, baby. Now let's talk about the thrombolytics. All right, so on to thrombolytics. I know, it's a lot, I promise, I know, but I think we're gonna have a really good understanding at the end of this. Just stick with me for a little bit, okay? I promise it'll make sense. So thrombolytics are the ones where you're like, bro, this guy's got a clot. Yo, hold my beer. And you give this medication, boom, clots exploding, all right? They're truly breaking down a clot. These two, they're more inhibiting the clots from getting bigger or preventing the clots from forming. That's what they're truly designed for. This one, you got a clot, shaboom, right? You throw this one like a grenade, that thing's popping open. So how do we actually do this? Let's go through the normal mechanism first. So here we have a molecule called plasminogen. And plasminogen is acted on by this enzyme called tissue plasminogen activator, right? TPA. That converts plasminogen into plasmin. Now, you guys remember that here I'm going to have this molecule. We're going to call it factor 1, and that was called fibrinogen. And fibrinogen, as we indicated before, is just a bunch of monomers. But when you take fibrinogen and you combine these together, right, in the presence of thrombin, and right, that's the big one. Who was the one that catalyzed it? Because remember, again, factor 2A was the one who catalyzes this step here. Catalyzes it and helps you to form what? 1A. And 1A is fibrin. Now, here's what's really important, because fibrin then goes on and you get your fibrin mesh. Right? This is going to form your fibrin mesh. And then eventually that leads to your thrombus. Right? So we have this normal pathway which plasminogen is converted into plasmin via TPA, tissue plasminogen activator, and plasmin will then go and break down fibrinogen and break down fibrin. And what you break it down into is all these little degradation products. So I'm going to break this one into all these little degradation products. So now I'm going to stimulate this step here, and what I'm going to do is I'm going to deplete my fibrin, so that I get less of my fibrin mesh, and I decrease my thrombus. I actually break the thrombus down. I also decrease my fibrinogen so that I end up with less fibrin mesh, less thrombus. And I break these down into fibrin degradation products. Fibrin degradation products, right? And you'll get a lot of these little suckers here, right? Sometimes we can get D-dimers out of this too, right? So you get fibrin degradation products, which includes D-dimers. So the concept here is that this enzyme, which is your tissue plasminogen activator, your TPA, this dude is catalyzing this step, right? He's catalyzing it. So what if I had drugs that act like TPA? And all they're going to do is they're going to literally work here and catalyze it even more. And then I'm really going to end up with a lot of plasmin. I'm going to end up with a lot of fibrin degradation products. I'm really going to deplete my fibrinogen, deplete my fibrin, deplete my fibrin mesh, and really break down my thrombus. That sounds pretty attractive, right? And so that's what TPA is. And so there's a couple different types. Alteplase, very commonly utilized drug. Tenecteplase is becoming a little bit more commonly utilized now. And then retaplase, I haven't seen this one utilized too often, but alteplase and tenecteplase, pretty common. Now, the benefit of these drugs is, again, they are breaking down a clot. So when you talk about antiplatelets and anticoagulants, those are inhibiting clot propagation formation. Thrombolytics are literally breaking down a clot. So it's really important to remember something. When you give this, it's actually kind of beneficial. Remember I told you like we monitor things? When you give TPA, monitoring the fibrinogen could actually be helpful if a patient begins to develop bleeding from this. All right? Our goal is to keep it greater than 150. So if it's less than 150, it actually may indicate the need to reverse the actual TPA itself. All right? And so I think it's worthwhile to consider that as an important feature. All right, let's talk about when we give these little TPA molecules. So we give this in really a couple indications. Patient comes in with a PE. And so when we say massive PE, I'm talking that they have what's called RV strain, which you can see on echo, and they have a decrease in their blood pressure. So they have hemodynamic instability. In these particular scenarios, we call this a very unstable PE patient. This is a patient you need to give TPA for, and you give a pretty good dose. Now, if they have a contraindication, you may go and do like a pulmonary embolectomy in that scenario, but oftentimes this is the way to go about it. So you're probably like, oh, PE, don't you give anticoagulation? No. So you only give those in like the patients who are not having significant kinds of RV strain and hypotension. We could also give this in cardiogenic shock as well, but that's a big one there. Acute ischemic stroke is a really important one. So if a patient comes in and they start having, like, let's say a clot here in the MCA, and so as a result, they develop some infarct within the MCA territory, right? And so they come in with a neurologic deficit that's suggestive of a particular vascular territory. They have come in with a last known well less than 4.5 hours. And on their imaging, they have no bleed or no contraindications against this. In other words, they have a recent bleed, they're on anticoagulants or something that's contraindicating it, their blood pressure is way too high, they had surgery recently on their spine or on their brain, something like that that contraindicates them, then you can't give the TPA. But in these particular scenarios, that's when you say, all right, if these three potential criteria are there, then what I'll do is I'll go ahead and give them the TPA, all right? And then afterwards, you treat the underlying issue. Is their stroke due to an embolic source like AFib, anticoagulation? Is it due to atherosclerotic cardiovascular disease, aspirin, right? So important things. Now, these are the two primary indications. There is additional scenarios. I don't want to go too much into them, but if a patient does develop something like a STEMI, so they develop a ST segment elevation MI, and there's no PCI. So let's say generally you have PCI available to you, then you go to PCI, all right? Which is when you get the stent placed, right? So if you have PCI available to you, you go to PCI. If you don't have PCI available to you, so it's not available, then what you're gonna do is you're gonna do TPA. And then if possible, get them to a facility as quick as you can and under that 12-hour frame to do a PCI. So that's the ultimate goal for these patients. Another one could be catheter-directed stuff. So catheter-directed. What I mean by that is if you have like a central line that's clogged up, we can put TPA to kind of break down the clot in the central line. Another one is an extensive DVT. So if you have extensive DVT or something like that, like a clot in a vein, then you could consider squeezing in a little bit of TPA into the catheter near that area. But those are some niche scenarios. This is the two big ones I want you to remember. All right, that covers the thrombolytics. So at this point, we should have a pretty good understanding of when we give antiplatelets, when we give anticoagulants, when we give thrombolytics, right? Their overall mechanism, what they're good for, what we monitor for. What's the things that we have to be wary of if these medications are taken? Aspirin, you gotta watch out for peptic ulcer disease. The concept behind this is actually pretty straightforward. That aspirin, what it does is, it actually inhibits the cyclooxygenase enzyme, and that leads to a decrease in prostaglandins. Remember that? We talked about that? So it leads to a decrease in prostaglandins, especially prostaglandin E2. And the prostaglandin E2 is supposed to help with mucus production in the stomach, and that helps to form a protective barrier of the stomach. If you don't have that mucus production, then what happens? You get erosion of mucosa. And so it can start off with the gastritis, and in worst case scenario, especially with chronic use, this could lead to ulcers. And so having a drop in the prostaglandins leads to less alkaline mucus production, less protection against erosion, and if you get more of that erosion, you could potentially start forming a ulcer here. All right? So that's one thing to be wary of and to be careful of. Another one is Rye syndrome. So this one's kind of interesting. If a patient is taking aspirin, all right, aspirin's supposed to be taken up via the liver, and it should get metabolized, right? But let's say that a patient has a viral infection. So they're less than 19 years old, and they have a viral infection. And so the concept behind this is if you have a viral infection, you get like a fever, what may you reach to get rid of a fever? An anti-inflammatory. Aspirin is one. You should give Tylenol instead, but if you accidentally give aspirin, what can happen? Well, the viral infection, what it does is it can actually act on the liver, and what it does is it alters this metabolism process. And so what ends up actually happening is you metabolize the aspirin into a toxic metabolite. So it's actually represented here as like being a toxic metabolite. This toxic metabolite then starts causing a decrease in the ATP production. So it actually causes mitochondrial damage. So that's the first thing it'll do. So it'll cause damage to the mitochondria. Mitochondria damage, and then that leads to a decrease in ATP, and that leads to hepatocyte death. So now I get mitochondria damage, a drop in my ATP production. The cells can't survive if they don't have the ATP. The cells die. And then what happens is you lose the ability to clear ammonia, and they end up with hyperammonemia. All right, so that's one really scary thing here is they can end up with a very high ammonia level. They can't go through the urea cycle as well, and they end up with a very high ammonia level. And this can start causing encephalopathy. The other thing is if your hepatocytes die, you lose the ability to make coagulation proteins. So they can end up with also liver failure, and that causes coagulopathy. The other thing is if the hepatocytes die, you can end up with an increase in LFTs. So you want to watch out for an increase in their LFTs, encephalopathy, and also a decrease in coagulation proteins. And that leads to a coagulopathy. This is oftentimes we'll see a elevated INR, right? So this is kind of the things that we look for is this acute kind of like hepatic failure that can cause coagulopathy when INR greater than 1.6, elevated LFTs, and encephalopathy. This is a form of acute liver failure, right? P2Y12 blockers, they're actually pretty well tolerated. Clopidogrel is a pretty good one. Big thing I told you about before to watch out for is if they're a hyper-responder or an under-responder, you check that P2Y12 level and that gives you a good idea. Ticagrelor can cause like random dyspnea sometimes, and then prasugrel is a higher bleeding risk. But for the most part, they're good. There used to be an old age drug. So there was an older generation, P2Y12s. We don't use this one anymore, but it's called ticlopidine. And ticlopidine is a terrible drug because what we found is that this drug may activate kind of an immune response. And so your plasma cells may produce antibodies. These antibodies may be directed against certain types of proteins in your body. One of them is called the atom TS13. It's going to inhibit this enzyme. If this enzyme is inhibited, it's no longer going to be able to break down the von Willebrand factor multimers into monomers. This process is inhibited. You end up with more of these multimers. This combines with our friends. Where is my maroon marker? Right here. This will combine with a bunch of your platelets. And what are you going to get out of this? You're going to get a good thrombus in your smaller vessels. So as a result, I'm going to end up with what's called a thrombus. So I'm going to have a thrombosis. But the other thing is, in order for me to form this thrombus, I have to consume platelets. And so the platelets drop. All right. And so what ends up happening is you get a mnemonic that we oftentimes use for TTP, which is thrombotic thrombocytopenic purpura. You want to remember the mnemonic. So let's actually write this right here. Mnemonic. Spelling challenge today, huh? Is FAT RN. F is for fever. A is for anemia because they consume the red blood cells as they run across that thrombus. T is thrombocytopenia because you consume the platelets to make more of that thrombus. R is because the thrombosis blocks the blood flow to the kidneys and you get renal failure. N because the thrombosis blocks the blood flow to the brain and you get neurological symptoms. All right? Big thing to remember is the ticlopidine. The other thing is that ticlopidine can actually cause suppression of your bone marrow. So watch out for neutropenia as well. All right. Now, heparin, big thing I talked about is HIT. So HIT is when you give heparin, and HIT is more commonly associated, I'd say when you talk about this one, it's going to be unfractionated heparin more so than low molecular weight heparin. Another reason why this makes it attractive. But when you give heparin in certain patients, after they take it, about 5 to 15 days later, the heparin will bind to the PF4. When it binds to the PF4, you get this heparin PF4 complex. So now I have a heparin and PF4 complex. Believe it or not, this is highly immunogenic. So then what happens is I develop anti-PF4 antibodies. The anti-PF4 antibodies interact with the heparin PF4 complex. When this happens, it activates the platelets. So I'm going to stimulate my platelets. These activated platelets then start getting consumed, and they start helping us to make clots. So now I'm going to end up with a thrombosis. And if I end up with that thrombosis, that could cause a DVT to form, a PE to form. I could even get clots in the arterial circulation. And so it's really important to remember that that's a potential complication. But on top of that, they also develop thrombocytopenia because they consume their platelets. So it's really important to remember a patient who has heparin use, who develops HIT, you want to remember thrombosis, heparin exposure, but also because of consuming the platelets to make the clots, watch out for a drop in their platelet count, at least greater than 50% after the use. Last one is warfarin. So warfarin can cause something called warfarin-induced skin necrosis. And this is one of the reasons why we give heparin as a bridge prior to kind of just starting off warfarin on its own. So what happens is warfarin, when it's taken, what it does is it acts on the liver, right? Inhibits the vitamin K epoxide reductase, and that leads to less synthesis of those essential clotting factors, the functional clotting factors, such as factors 2, 7, 9, and 10. But I didn't tell you about the other ones. These are the ones that are going to help with the procoagulant activity, but it also makes protein C and S. So whenever you give warfarin, it inhibits the vitamin K epoxide reductase, you drop these levels and you drop these levels. But the problem is that this has a shorter half-life. So the T half-life on this one is pretty short. All right? So what happens is these will drop quickly. All right? So if a patient has protein C or S deficiencies, now add into the mix. Let's say you make it more complicated. If a patient has protein C or S deficiency, let's say that they have a true deficiency. This is an inherited thrombophilia. All right? If they have an inherited thrombophilia, what this will do is, again, let's actually say that this is inherited. Let's add that on. An inherited protein C or S deficiency, what it'll do is it'll drop their protein C and S levels even more. When you drop these levels even more, guess what this does? This causes, you know what these are supposed to do? They're supposed to inhibit, so let's actually put it right here. Protein C, what it really wants to do is it wants to inhibit factor 5 and it wants to inhibit factor 8. That's what this wants to do. It wants to inhibit these two factors, kind of inactivate them, right? These are supposed to help with clotting. If you have lots of protein C, then what will you do? You'll inhibit these guys and you won't clot. But if you have low protein C, what are you going to do? I'm going to actually not be able to inhibit these anymore. They may become active. This may become active. So then what ends up happening is you end up with a loss of control for factors 5 and 8. So your factor 5 and 8 levels may go up, or at least have increased activity. So let's say increased factor 5 and factor 8 activity. That means you're hypercoagulable, bro. If I'm hypercoagulable, and this is during the first 3 to 5 days, so this is about approximately 3 to 5 days. That means I have a hypercoagulable state. In that scenario, guess what I'm going to do? I'm going to lead to a thrombus. Because I'm going to end up activating my coagulation system. And I'm going to end up with thrombosis, bro. And if I end up with a thrombosis, especially of the cutaneous vessels, I clot off the blood flow to the cutaneous vessels, I can end up to necrosis to that skin. It actually looks a little bit like this. We really can prevent this warfarin-induced skin necrosis by doing what? Start them off with heparin and then get the warfarin on board. While the warfarin is working in the 3 to 5 days, you keep them on heparin because in that transient period, they're hypercoagulable. The heparin will prevent them from developing thrombosis. Then after that 3 to 5 day window, guess what happens? These levels start to drop eventually because these lag behind. This one drops first and these lag behind. After that 5 day kind of time frame hits, drop the heparin and just keep your warfarin on. And now you're in an anticoagulant state. So that's how we kind of do it. We put them on heparin, warfarin. First 5 days, we kind of get them out of the hypercoagulable state, drop the heparin off. We're in the full anticoagulant state. These are full flaming and depressed action. Boom, you get your anticoagulant activity. Now, the last thing that I want you guys to remember is when a patient has any of these medications on board, antiplatelets, anticoagulants, and thrombolytics, they're at high risk of bleeding. What I want to do is I want to tell you guys some of the big things to remember. And so Whenever a patient develops bleeding, I think it's important to remember what are the high ones that are high risk for bleeding. And actually, we're going to kind of go backwards. The most high risk for bleeding is with thrombolytics. Then anticoagulants, but which one? Warfarin is the next one. Then after that, it's kind of a combination between your DOACs, which is your thrombin and 10A inhibitors, and heparin. Those are kind of together. Then we go to the antiplatelets. GP IIb/3a inhibitors are the most. Then we go to the P2Y12 blockers. Then we go to aspirin. So the bleeding risk is really important to remember. What are some of these things that you have to watch out for if a patient bleeds? First one, watch out for intracranial hemorrhage. Watch out for GI bleeds. Also, be very careful if a patient is exsanguinating and bleeding and they're on these medications. In those scenarios, when a patient is bleeding or they're getting ready to have a surgical procedure, you may have to reverse these medications. Let's talk about that now.
Now, if a patient by chance is taking one of these drugs and they start to bleed, we don't always just jump to reversing it, but I would very, very quickly jump to reversing these drugs if they have severe bleeding that's uncontrollable. Or maybe it's other bleeding like, gingival bleeding, epistaxis, hematuria, menstrual bleeding, and I've tried all my conventional methods, but they still continue to bleed. Obviously, discontinuing the medication is first, but reversal agents can potentially come into play. Antiplatelets, we don't do this a lot, but you could transfuse them with platelets, and sometimes you can give them DDAVP. If you remember, DDAVP helps to activate our endothelial cells to produce von Willebrand factor, and von Willebrand factor is needed for platelets to stick to, and that helps to form potentially a platelet plug. So that may be some ways that we can consider. I would say this is not often that we do this. Maybe in a neurosurgical scenario, we would give antiplatelets. If a patient's getting ready to get a surgery or some type of neurosurgical procedure, we may try to reverse the antiplatelets, but it's not guideline based. Heparin, this is one. So if a patient is bleeding and they are exsanguinating or they're having a potential complication or they need to get a surgery and we need to prevent them from having massive bleeding, we will give reversal agents. And basically, again, this is going to be, heparin is an increase in the activity of antithrombin 3, which suppresses factors 10, factors 9, and thrombin. What I want to do is give something to inhibit this, and that's where protamine sulfate comes into play, pretty commonly utilized. All right, and that's going to suppress the antithrombin 3, which again is going to help to increase the activity of 10, 9, and 2, and that's going to help them to be able to clot. All right, because we don't want them to be bleeding if they are bleeding or they're getting ready to get a surgery, which predisposes them to more bleeding. Warfarin is a very common one. I see this a lot in the neuroscience ICU patients who come in. They're taking warfarin for atrial fibrillation, and all of a sudden they develop a intracranial hemorrhage. Now, this one is commonly given with a two-part drug. We give them IV vitamin K and prothrombin complex concentrate. The concept here is you give the IV vitamin K because it's helped to stimulate the liver to produce factors 2, 7, 9, and 10. And then you give them 4-factor PCC, which contains factors 2, 7, 9, and 10. So you rapidly replenish the levels, and then over the next 24 hours, the vitamin K kicks in and really helps to bump up that 2, 7, 9 production. All right, direct factor 10A inhibitors. Again, we don't have an actual guideline basis, but this one, you can just give them PCC. The reason why, what's in PCC? Factor 10. And what are you inhibiting? Factor 10. Same thing, there's another drug. Again, it's not been shown to be super efficacious, but it is considered to be an antidote in scenarios of direct factor 10A inhibitors, and that is andexanet alpha. Super, super expensive and has about the same efficacy as PCC. But again, it's a direct factor 10 kind of drug where we can actually have an antidote in the sense that it's literally blocking these direct factor 10A inhibitors like apixaban or rivaroxaban. Now, this next one is super high yield, really important to remember. Direct thrombin inhibitors, and when I say these, I'm only talking about the oral drug, dabigatran. Dabigatran, if a patient is bleeding, we would give them idarikizumab. All right, so the really important ones to remember: heparin, protamine sulfate, warfarin, IV vitamin K, and PCC. Direct thrombin inhibitors, only dabigatran, idarikizumab. Now, for thrombolytics, these are scary ones. These patients can really, really bleed. And really the only time whenever you have a patient who bleeds, we give them tranexamic acid, but we also check their fibrinogen levels to see what their cryoprecipitate level is. To see what their fibrinogen level is. If the fibrinogen level is less than 150, oftentimes we will also give them cryoprecipitate. Because cryoprecipitate, guess what it's rich in? Fibrinogen. And so you'll replenish their fibrinogen, also giving them TXA to help to basically inhibit that fibrinolysis process. All right. And this again gives an idea of how we're working to basically reverse these unfortunate mechanisms of action in patients who are taking these drugs for preventing clot propagation or preventing them from developing a clot or basically breaking down a clot, but unfortunately they develop bleeding as a result. We will give these medications to reverse that. All right, my friends, this was a monster lecture on antiplatelets, anticoagulants, and thrombolytics. I really hope it made sense. I truly hope that you guys enjoyed it. Love you, thank you, and as always, until next time.